Stanford. Some of the things that I'm really passionate about is the inpatient navigation. Those patients who come to the hospital, either they come for an elective surgery or they may come in through the emergency room. And then to move from one discipline to the other, you may come in with a broken hip, but then if you move to neurology or cardiology, what are some of the handoffs? What are some of all those details? And then supporting discharge planning. A big part of our job is to really connect with families because this is not something we face alone. It is aging adults and their families. So it's sort of a whole combined approach that we've taken. Aging Adult Services has become the primary resource for aging adults within Stanford Hospital. Our new hospital and our speakers here today after me are going to be addressing that, but I'd like you to read the little statement here, which says, "Great things are done not by impulse, but by a series of small things brought together." And I think that the creation of the new hospital, the renovation, everything that we do every day to help you navigate through the healthcare system, these are all small pieces of knowledge and data that we've combined together to serve you better. Now, why are hospitals hard to navigate? On a day-to-day basis, we take care of patients, we look after them, we meet them in the clinic, we meet them in the hospital, we do home visits, and these are some of the things that we've discovered. Illness, pain, visual impairments, hearing, impaired mobility, that is the inability to walk long distances, cognitive impairment, multiple layers of communication. The clinic told you about a certain appointment. Did they tell you the address? You go to a different site, and from there to move around. The lack of support, and by that I mean, are you going to your visits alone? Is somebody taking notes for you if you cannot do so? Is somebody translating all what you learned back to your home or to your family? Transportation, that is one of the biggest problems we face. And we do have a volunteer-based transportation program. Who is looking at the big picture? As you navigate between diverse disciplines, diverse medications, who is looking at the big picture? And that's what gerontology and geriatrics really does. It's a branch of internal medicine that looks at the total body. And it's important to note here that, when you take a 10-year-old child to the hospital, you need different kinds of eyes looking at a 10-year-old versus a 35-year-old. So there should be something different looking at a 70-year-old or a 90-year-old. And that's the basic premise of geriatrics and gerontology. So when we did some focus groups with some of our patients and families, and we asked them, what are some of the things that you would change if you could in the hospital? And this is a nationwide initiative where people are talking out and saying we need a better structure, a better layout. And so Stanford has looked into these multiple clinic sites, distances, lighting, sound. And I'd like to share something really quick here. One of my specialties is dementia management, cognitive impairment. I cannot tell you the impact of light and sound. Right now, 3 units in the hospital just went live with what they call diminished sound, that they put in filters. People are sleeping longer and not using sleeping tablets because of the sound and the noise that's being suppressed. The flooring, very critical, doors, restrooms, waiting areas, hospital room layout, the signage, and our very busy emergency room. Any of you have been to the emergency room, it is so busy. And so all of these have come after discussing with people that these are areas we really need to look at because they impact care outcomes. What is an optimal physical environment in a hospital going to do for us? Enhance safety, functional level, reduce the risk of decline due to accident, delirium, and immobility, and lower the potential risk of harm decreasing hospital stay and cost. I just wanted to take a minute here. Most aging adults are at risk for what we call postoperative delirium because of the anesthesia and the pain medication. And you need to have a special setup when you come out of surgery to be able to take care of sleep and all the other variables that combine. And delirium is short-lived, but that does impact. And when you have somebody who stays in the hospital longer, you have problems with lying in bed and respiration and skin. So all of those little details add to that. I want to say that many variables come together to create a sense of care and well-being. Before I end, I want to also mention that our program, which is running 24/7 now, has several programs, has several services, and we are out in the community doing a lot of work. We have several partnerships with different senior centers, especially with Avenidas, and you can always look us up on the website. If you can't take down the name, if you just do geriatric health at Stanford, our site pops up. And what I've tried to do is combine all the other different initiatives at Stanford and kind of bring it together so we present you with a continuum of care. And I'd like to leave you with these 5 very tested principles. And I follow these every day, and I tell everybody to follow them. That education is a predictor of sustained mental health. Physical exercise enhances the nervous system, especially memory. Self-efficacy. If you have self-efficacy, you will be your own advocate. You will take charge, and you will do well with your health system. Low self-esteem reinforces resignation. And then finally, as we hurtle into our 80s and 90s, we are seeing more and more cognitive impairment. And one of the things we see is social support and engagement has a very positive effect on as we age. So I'm available by email and by phone, and we literally pick up our phones all the time. So if there's any questions, I'll take it at the end of the presentation.